Yes, Kalpana, we will start.
Good evening, everyone. It's my pleasure to welcome you all for a Marathon CME organized by Tnfog. We have wonderful chief guest, Sunita ma'am, who will be sharing her words of wisdom and blessing for our CME. It's my pleasure to invite Sampath Kumari ma'am to give an intro about this CME.
Good evening to all. This is our first CME after our new president, Dr. Revati Madam, has taken over as Tnfog president. This is the Marathon CME, which we will conduct on every second Friday of every month. Here we will have one UA session and the consultant session. After each session, we will have some questions for the delegates. Prizes will be given to the delegates. So it is called as Marathon CME. Even for the UA, at the end of the year, we will give the best UA presenter in our annual conference. So this is Marathon CME. Here we have good speakers and our president of Revati and our chief guest, Dr. Sunita Tendulkar, who is the future FOG president. And now I invite all the delegates for the wonderful Marathon CME. Sakiti, you can play that Tamil Thai waltz and the lamp light. Now we will go with the lamp lighting and join the lamp lighting. Sakiti, you can put the lamp light.
જ્યાં સુધી ઊંઘશે નહીં ત્યાં સુધી આપણી મેથી મારતો
Kalpana, you can introduce. Welcome, Dr. Revati Madam. Unmute. You are muted. Kalpana, you are muted.
It's my pleasure and privilege to invite Tnfog President, Dynamic Revati Janahiram ma'am, to deliver her welcome address. Madam doesn't need any introduction. She's well known to South India and national level also, past Vice President FOG. Now she is the current president of Tnfog and past president of AMOG's IMS Madurai chapter and present president of YMCAT. Welcome, ma'am, to deliver your welcome address for this wonderful Marathon CM.
Thank you, Kalpana. And it's indeed my great pleasure to welcome all of you, especially Dr. Sunita and all. And after becoming president of Tnfog, this is the first Marathon CME, as Dr. Sampath was telling. And we never want to leave anywhere. So in spite of all tight programs Sampath has got, she managed to organize this first CME also. and the topics are really very good. And I wish that we will continue this marathon, Magalin Nalam, and all those CMEs also. And also planning to have more and more joint ventures with other federations, not only in South but also all over India. And I am sure we'll get cooperation from all. And always we Foxicians are all united, and especially in South, we are too much united, and that is proven by this Tnfog. And on behalf of Tnfog, I welcome all of you to this wonderful marathon CME. Thank you.
Madam, you can introduce Sunita Madam.
Sunita,
Our chief guest.
it's my great pleasure to introduce Dr. Sunita Dandalwalkar. And in one word, now she is going to be the Foxy president now. And she is HOD, Department of Gynecology, Ruby Hall Clinic, Pune. She's the founder and medical advisor of Solo Stem Cells and co-founder of Solo Research Foundation, President Fox, and past President IAGE, Chairperson of Maharashtra Chapter of ISA, Joint Secretary of Indian Society of Assisted Reproduction, Founder Secretary of Maharashtra Chapter of ISA, BP West Zone Foxy 2017, and she has been elected as board member, International Society of Gynecological Endoscopists, because she is very good at endoscopic surgery as well as lectures on endoscopy, which we saw in our Madurai OG Society conference also recently. And she's the chairperson, Foxy Infertility Committee 2011-13. So with great pleasure, I invite you, Dr. Sunita, to say a few words and your blessings.
Thank you so much, ma'am. First, Revati ma'am, thank you for your kind words and a beautiful introduction. And thank you for announcing that I'm going for my Foxy presidency. That was much needed. Revati madam, I'm watching you since my birth in a Foxy, because you are so senior and I used to see you and you are the same. And I really pray today, God Almighty, to keep you such a happy and healthy for decades to come, I'm not joking, ma'am. You are the same. When flower se leke, tilak se leke, everything, ma'am, you have not changed. It's pleasure and I congratulate you with your team to conduct this marathon webinars on second Friday, when you have Sampath Kumari as a secretary. Nothing less you can expect. You will have n number of physical, you will have many webinars and brainstorming webinars. I was seeing today's topics of lectures, which are so important for a routine gynecologist, the dysmenorrhea and stress and infertility, and very wisely chosen faculty, Dr. Subhashini and Dr. Jairani. I'm very sure Dr. Jairani will say so good about stress and infertility, and she will relieve the stress of all of us. At the same time, I was wondering, the panel, who is conducting the panel, and I saw Madam herself is conducting the panel. That was a fantastic thing. And though I may not know everyone personally, I see them quite senior. Dr. Radha Madhvi, very senior joint secretary of a TNFOG. I see Dr. Manomani here only. Dr. Lakshmi Krishna also I saw join. Dr. Padma I saw joined. And I'm very sure this will be a fantastic webinar, and thank you so much for giving me an opportunity. I absolutely agree that TNFOG is always rocking, either in this form or that form. And today you have Dr. Sampath Kumari, who is a vice president of Foxy. So listen, ma'am, vice president of Foxy also works under you. Take a pride. I used to say the same to Dr. Anja Lakshmi madam. She was also very kind. She has given so much love and so much passion in her work, and she kept the TNFOG very grounded. When you say our South India is very much together, it's like a 5 fingers with one hand. That credit goes to the leaders of this. I just had a jhalak of Dr. Ajita or Dr. Vidya, all South India, so much of academics, so much. And when there is academics you hype for, naturally the unity comes. The rest of the country, probably they fight for some other reason. And that's where the unity get disintegrated. When you keep a goal as a woman health, you keep academics as your goal, then the respect, the mutual respect comes automatically. And that's what I see when I move on to South India. Every state has a different culture, totally different culture. But what binds together to everyone is their own culture of academics in their blood. And that's where you stand out among the entire Foxy. Thank you so much, Sampath Kumari and Revati Madam, to give me an opportunity to be on your very first webinar, to come here and actually to take a blessings from you yourself. Dr. Sarvan Kumar, thank you for a beautiful goddess and God behind. I always keep on watching them wherever they are. They keep on sending us the positive vibrations. Thank you for having me here, and I wish you all the best for your entire curriculum.
Thank you.
Dr. Sunita, all the best.
Thank you, dear. Thank you.
I request everyone to look for Dr. Sunita. She is very fantastic for Foxy Presidential 2020.
Thank you.
Thank you. Yes, madam. It is something
Thank you.
Kalpana?
Shall we move on to the academic session, ma'am?
Yes.
Yes.
Yeah, with the blessings of Sunita ma'am, who has got very bright future in Foxy in the nearby coming years. We move on to the academic session. It's my pleasure to invite Mary Annie ma'am, our chairperson, who is well known to Tamil Nadu. Madam was the past president of Nagarkoil Oji Society and very hardworking person, had done excellent work in adolescent gynecology. Welcome, ma'am, as a chairperson. Our next chairperson is Dr. Saravana Kumar, who is the secretary of Salem Society and also treasurer of Tnfog. Had done excellent job as a secretary of Salem Society. Welcome, Dr. Saravana Kumar. Over to you, chairpersons, for the further proceedings.
Saravana Kumar, you can introduce Dr. Subhash.
Mary ma'am.
Am I audible?
Yes, Saravana Kumar, audible.
Okay, I welcome the first speaker, Dr. Suhasini Karnar. She has done her MBBS from Chengalpet Medical College, DNB in CSI Rainy Hospital at Chennai. Her additional certifications are laparoscopic training at St. Paul's Hospital, Kochi, USG training course at Selvi School of Sonology, Chennai, and the current designation is working as an assistant professor in Muthukumaran Medical College for the past 7 years. She'll be talking about dysmenorrhea. Over to you, ma'am.
Thank you, sir. Thank you for the wonderful introduction, sir. Just start screen sharing.
Dr. Subhasini.
Ma'am, I'm just sharing my screen.
Ma'am, please open the PPT first and then start sharing, ma'am.
Rita, we have a cyclone today and tomorrow. The government has announced. In spite of that, we have sufficient numbers for our Oxy conference, and here delegates are also good. Anyway, it's nice to see our delegates.
I know.
Today night, I think it may cross
Yeah.
cyclone.
Ah,
Subhasini, என்னாச்சு?
Ma'am, இதை share பண்ண முடியல, ma'am.
Open பண்ணிட்டு minimize பண்ணிட்டு then you start sharing.
செல்போன்ல ஷேர் பண்றியா?
ஆமா மேம், அதுதான்
செல்போன்ல கொஞ்சம் கஷ்டம்.
Ma'am, any problem in sharing?
Yes, ma'am, I'm not able to share.
Otherwise, you send it by mail to somebody and then they can share.
Okay, ma'am.
Ma'am, I'm sending my mail ID, ma'am.
கல்பனா பேனலிஸ்ட் எல்லாரும் இருக்காங்களா பாரு, இருந்தா நம்ம பேனல முதல்ல ஸ்டார்ட் பண்ணிடலாம்.
ஓகே, வந்திருக்காங்களா எல்லாரும்? பார்த்து 5 பேர் தானே.
மனோன்மணி மேடம் இருக்காங்க, லட்சுமி பிரபா இருக்கா,
ராதா மாதவி காணுங்க.
சரவணகுமாரியும் பேனல்ல உட்கார சொல்லலாம்.
Meanwhile, we can start and call other panelists also.
லட்சுமி கிருஷ்ணா இஸ் தேர். சண்முகவடியும் இல்ல போல இருக்கு.
ஆமா, சண்முகவடியும் ராதா மாதவியும் காணும்.
சுபாஷினிதா
அதான் என்னன்னா any difficulty in joining?
சுபாஷினி
மேம் இது ஸ்கிரீன் ஷேர் ஆக மாட்டேங்குது மேம்.
மெயில்ல அனுப்பிச்சிட்டியா?
மெயில் ஐடி தெரியல மேம்.
Ma'am, I have kept in chat box, ma'am.
சூப்பர்.
சரிங்க மேம். ஓகே மேம்.
நான் ஒரு மெயில் ஐடி அனுப்பிச்சிருக்கேன் பாருங்க, அதுக்கு அனுப்புங்க, நான் ஷேர் பண்றேன்.
சரி, அவரை சரவணகுமார் அனுப்பு, அதுல அனுப்பிடுவார்.
நான் ஓபன் பண்ணி வச்சிருக்கேன் என்னோட மெயில்.
So from the next month, we can have the theme, madam, Revathi madam. With the newsletter and the theme we can have.
I think we will start the panel. Meanwhile, we will call all the panelists.
I've asked Radha to join.
Radha illa, Shanmuga.
Radha Vanti, she is waiting that only 5 o'clock our panel. I asked her to join now.
Otherwise,
Madam, Tiruvannamala
Radha Vanditaka, we can start.
Ma'am, Radha ma'am has joined, ma'am.
Okay, fine, then we can start, no problem. Shanmuga மட்டும் யாராவது phone பண்ணுங்கப்பா. We'll try.
Phone பண்றேன். Yes, madam. Saravanakumar, you can introduce Dr. Subhashini again. We will start with the panel now. Revathi madam, are you ready?
Yes.
Yes, Kalpana, you can introduce the Revathi madam and the panelists.
yes, as I've already introduced Revathi ma'am, who is
You can introduce the panelists.
It's my pleasure to invite all the panelists for this wonderful panel. Radha Madhavi ma'am, who is Joint Secretary of Tnfog and also President of Tiruvannamala, and has been invited as a faculty for various conferences. She has recently delivered her wonderful lecture in Madurai Annual Conference. Welcome, ma'am. Our next list is Dr. Lakshmi Krishna, again very close to me, who was my co-coordinator in Tnfog infertility workshop also. She is a joint secretary of Erode Society and very dynamic person. Welcome, Dr. Lakshmi.
Thank you, ma'am, for your warm welcome. Thank you, ma'am.
Our next is Dr. Shanmuga Vadivu, who has got almost 16 years of experience and has been teaching experience in undergraduate and postgraduate students, published various papers in national and international journal. Welcome, ma'am. Our next panelist, Manoonmani ma'am, who is the president of Coimbatore Roji Society and HOD of Coimbatore Medical College. She has received various awards, Best Outgoing Student MMC and Johnson Medicalist MMC, various awards, and she was past secretary of Coimbatore Society and managing committee member of Coimbatore 17 to 19.
Thank you.
Thank you.
Thank you. Thank you, Kalp.
Thank you. Saravana Kumar, you can join, I think. Padma. Dr. Padma is she is a member of our Chennai Society, and she is a treasurer of Chennai Menopause Society chapter, and she has UG from the Medical College, and she is now consultant at Apollo College, and she has joined Indian Menopause Society from 2014. Dr. Padma, I'll give you a call to her. Madam Revati, madam, you can start the sharing.
Okay, I'll share.
Saravana Kumar sir, you can join.
Yeah. I hope my slides are visible now.
Yes, madam.
Yes, ma'am.
Anyway, next is not moving. Yeah. Good evening, all. Now, the topic menopause hormone therapy is really an interesting one nowadays. And the starting of menopause hormone therapy, this evolved long back by giving the prescription of sheep ovaries in sandwich to menopausal women to make them healthy and happy. But actually, the FDA approved prescription for menopause hormone therapy. This hormone therapy started from 1940s. Since then, there was a fluctuation, just like a roller coaster ride, ups and downs depending upon the various results of the research studies. And I have got a good number of panelists, expert panelists, who are going to give us a clear-cut idea about this menopause hormone therapy. Now, because of these ups and downs, as on date, what is the stand of the MHD at present? Can Dr. Manonmani say a few words on that?
Now that it actually, after so many studies, the health studies, and other studies have come up. Earlier, it has been rejuvenation of the sexual life and everything, but nowadays it has been changed. So it should be considered. Previously, it have to be given for everyone. It can be given for so many years and all those things. But nowadays, it has been changed as it is only within 10 years of menopause. It is of no use after that. And you have to analyze so many risk factors. And if they are healthy and less than 60 years, and the hypertension doesn't increase the cardiovascular risk factor. And we have to, depending upon the symptomatology, we have to give. It is not like, not for everyone. So it should be a tailor-made. So depending upon the symptoms and what is the need of the women and how they are experiencing their menopausal symptoms, we can give. We needn't give it for each and everyone. And majority of the times we don't prefer oral routes, only a local application, transdermal or vaginal applications.
Exactly.
And we have to think of,
Yeah, so various changes have, because earlier we were all giving tibolone or estrogen therapy for all. But after this WHA, there was a standstill. Everybody was feared about the usage of hormones at all, and we totally stopped using the hormones. Now, reanalysis of the WHA study has resulted in proper usage of the hormones for menopausal management. Okay. Now, there are various symptoms with which the patients approach us, but we never realized that this is linked with the menopause, and we have got a treatment possibility also, like hot flushes, night sweats, sleep disturbances, vaginal dryness, discharge, urinary symptoms, and depression, anxiety, so many things. Right from head to foot, every system is affected during menopause, and they come with some symptom, not only after or at the time of menopause, even prior to that, during the menopause transition also. And it is up to we gynecologists to understand the pathology what symptoms are occurring and how it is related to menopause, and what best we can give the patient to get rid of these symptoms. Now, the main fears are that when we give hormones, not only for the patients, but also even for the gynecologists, the fear is still there. There may be development of breast cancer, increased risk of CVD, increased risk of venous thromboembolism, and also everyone is having the hormone phobia. If we take hormones, somewhere we'll get a cancer. So this is another problem with every patient. Okay. Now, each and everyone, you just look at it, breast cancer, actually we are overestimating. Now, in that case, are we not depriving a larger population which is not having the risk factors? As Manonvi rightly pointed out, we have to assess the risk factors and then we can boldly give the hormones. And CVD also, we can reduce the risk of CVD if you start the thing earlier. And again, if you take the proper hormone, then you can also decrease the risk of venous thromboembolism. And it is up to us to clear the hormone phobia of all patients. Now, the question is that these are all the things which we are going to discuss with all our panelists. Now, are we going to go? She clearly said that for symptoms, we have to treat them with MST. Now, is it necessary to go for MST? Can we opt for non-MST or an alternative therapy if it is available? Should we give it continuously or with a break of 7 days? Sequential or combined? What is the dose? Which progesterone? Which estrogen? Which route? How long? And when to start? When to stop? These are all the questions and confusions in everyone's mind. And I'm sure the group of panelists have got, they are going to give us, again, a clear-cut idea about each and every one of this point. Now, can anyone tell what are the hormones which we include in MST? Dr. Saravana Kumar or Lakshmi?
Ma'am, estrogen alone can be used, estrogen along with progesterone or progesterone alone. And we got androgens also to be used in case of where certain situations where androgen deficiency symptoms are also there.
Okay, of course, Tibolone also. Okay. Now, what are the indications for MST? When all can be given? As Manonmi said right from the beginning that we cannot and we are not prescribing MST for all menopausal women. Okay. Now, there are certain indications for which we are definitely we have to give. What are the indications? Radha?
When they are unable to manage with their menopausal symptoms, as you discussed earlier, madam, we can use alternate therapy and they are not relieved of their symptoms of menopause like irritability, genital urinary symptom, vasomotor symptoms, and back pain soon after menopause. All these conditions we are and anything surgical menopause occurring earlier than the required age group, say 40 to 45 or less than 45. All these are all indications for menopause hormone therapy if they are not relieved with alternative therapies as
now, do you all agree with that? That class, if not relieved. So that means to say that first option is other medicines. Is it so? All of you, all other panelists agree with that? Manonmani?
Madam, it is not like always we go for other hormone, other system of medicines. We have to analyze. So if the vasomotor symptoms, neonatal atrophy are more, and it will not be taken care of the other medication like proteins and all those things. Could be, maybe it will have only a placebo effect. But if you want to give them properly the treatment, then we have to go for the menopausal hormone treatment, provided we analyze the patient and we investigate, and we have to make, where to see that they are fit to receive the menopausal hormone therapy.
Okay. So there are definitive indications for which we have to give this hormone therapy, like vasomotor symptoms, urogenital atrophy. Both these things are proved beyond doubt that they are relieved by hormone therapy without any side effects, provided you choose the proper patient. Okay, that's number one. And also for prevention of bone loss, which we will discuss later in the case scenario discussion. And obviously, in premature ovarian insufficiency and surgical menopause, it is a must. You can't go for other alternative therapy. Okay, because something is lost much earlier, we have to replace it. Okay, so that is the different issue. So these are all the definitive indications. And what are the contraindications?
There is
Everything, madam. Dr. Padma is there.
Okay, I can't see. Okay, Dr. Padma, contraindications for MST. Shanmugadi has joined. Okay.
Padma ma'am, you are mute. You have to unmute. Padma, have to unmute.
Padma, can you unmute?
Ma'am, your voice is not audible.
Not audible. Padma ma'am, we are not able to hear you.
Okay, let her come. Anyway.
Ma'am, increase the system volume, ma'am.
Yeah.
Once check with your system volume.
Is Dr. Saravana Kumar there? He's joining us.
He's there. Saravana Kumar is very well there, madam.
Taranokar, you can tell.
Madam, I have to unmute. You are muted.
Madam, I'm a sudden panelist. I'm a little bit confused. I'm calling Shanmugavadi. She's not able to join it.
Okay, no problem. Now the contraindications are, as I mentioned, anything else you want to add? Like active endometrial or gynecological hormone-dependent cancers, active breast cancer, and of course, suspected pregnancy is not going to be there. Rarely around the menopause transition period, if there is a possibility of pregnancy. Undiagnosed abnormal vaginal bleeding, liver disease or abnormal LFT, and previous personal or family history of VTE and SLE. Anything else you would like to add, Dr. Saravana Kumar?
Medical disorders like porphyria, ma'am.
So these are all the relative contraindications like thrombophlebitis, a strong family history of breast cancer, fibroids, endometriosis, gallbladder diseases, and all. Now, headaches. Now, these patients, if they have severe symptoms, we can have a proper way of approaching them also. Okay. Now, okay, we are very clear that for symptoms, we have to start them on MSD. So if you plan to start an MSD, what are all the things you have to assess prior to starting? Lakshmi?
Yes, ma'am. Personally, coming to history taking, we'll have
very important.
Patient's age, how her menstruation has been, whether she has had any irregular cycles or menorrhagia. Coming to her past history, detailed history of whether she's diabetic, hypertensive. Also, when we do a physical examination, we have to see her BMI. That is most important. Especially her lifestyle, how she's, whether she's on the obese side, whether the history of smoking or alcohol consumption, all these taken into account. What are the medications she's currently taking, and also her family history has to be seen particularly, whether there's any family history of breast cancer or any hormone-dependent cancers also.
Exactly. And age is very, very important. Okay, because only then we can identify whether there is to assess the risk-benefit ratio. Okay, less than 50, the benefits are far out. Now that we have to remember one point: hormone therapy is, you can't say that totally it is safe. It has got some risk also, but you have to weigh the benefit as well as the risk. Under 50 years, if they got severe symptoms, definitely the benefits far outweigh the risk. 50 to, so they have to be given HRT, that is MST. And 50 to 60 years with the menopausal symptoms, again, the benefits are higher. But after 60, the risks are equal or outweigh. And after 70, the risk actually is even more. So better not to give MST after the age of 70 years. Now, time since menopause, again, it is very effective in preventing, especially because we are all the time worried about the cardiovascular risk only. And when the therapy is started within 10 years of menopause, the cardiovascular risk is very, very minimal. Actually, it will be more beneficial. Okay, that is very, very important. Now, what else? Examination part. Assessment. History, very important. Apart from that, you have to do a thorough examination, both general as well as local.
So rule out any of the systemic disorders, BMI,
Yes.
we have to see. And then especially waist circumference, and if it is more than 85, and then we can give them lifestyle modification also. And
very good. Very good. This point I want to stress. More than BMI, height, weight, BMI, waist circumference is very, very important. Okay, for the metabolic problems. So
because of the androgen,
how many of us know our waist circumference? How many of us know? Have you ever checked? I doubt very much. Okay, we have to, and we have to bring it under control. That is very, very important. Okay, then.
So then, because we have to be giving the estrogen progesterone combination, means then it will go for the breast examination as well, because mammogram is must after 40. So we suggest. So all the more important when the patient comes for MHD, we take the opportunity to do a mammogram. And as it has been put up, we have to go for any rule out systemic illness. So she has a diabetic, and you have to get the lipid profile, and as well serum thyroid profile and liver function test. And as mammogram and like occult blood. And if necessary, we can go for our DEXA scan also to what is the bone mineral density. And as we are starting the hormones, we have to go for the other checkups as well. Okay. As you have put up like eye checkup and
Thyroid and LFT and other systemic disorders, definitely they have to. Of course, incidentally, other routine things like pap smear, vaginal, transvaginal scan and all. Okay. Now, then we have to categorize the patient.
Revati madam,
Yeah.
1 minute. Fatma வந்து இருக்கலாம். என்ன ஆச்சு பார்க்கலாம். Fatma,
I didn't see her at all.
இல்ல இருக்கேன் நான் கத்திட்டே இருக்கேன்னு சொல்றா அவ.
Maybe she has got some network problem. Is it so?
மேடம் அவங்க இருக்காங்க ஆனா வந்து அவங்க பேசுறத கேட்கல மேடம். It is not audible.
Network issue நினைக்கிறேன்.
மேடம் ஷண்முடி ஜாயின் பண்ணிட்டேன் மேடம்.
Good. Welcome.
மேடம் பத்மாஸ் தேர் அவங்க நெட்வொர்க்
பத்மா
seeing videos.
அப்படியே என்ன ரிலீவ் பண்ணிருக்கு மேடம் பேனல்ல இருந்து.
பத்மா ஹலோ சொல்லு.
No.
அதுல வேல.
Audio
problem.
Audio's problem.
உன்னை இப்ப தெரியுது பட் வாய்ஸ் கேட்க மாட்டேங்குது.
You just try to find out the fault in your end.
Madam, log out IT, you can log in again.
That's better, or you can log in through another system also. Anyway, we have to categorize it as symptomatic or asymptomatic, healthy with or without risk factors, healthy with latent disease, with overt disease. So we have to classify, then only we can decide whether to give, when to give, what to give. Okay, that is very, very important. Now let us start seeing the few cases by which we can understand how we have to prescribe the MST. Now this patient is 48-year-old asymptomatic, just like any of our patients. She has just gone through the Google everything about menopause, and she is getting regular periods. Now she heard that she will have a lot of problems at menopause, and of course she has got permanent contraception by vasectomy, and general examination, investigations, everything is normal. Still, she wants to know what medication she has to take to avoid the problems of menopause. How will you counsel her? Are you going to give her any prophylactically at the time of menopause or after menopause, or at present, what are you going to give? She has not yet attained menopause. She is expecting her menopause anytime, so she wants to know this thing. How will you advise her?
A question to whom?
Shanma, what do you?
Madam, if she is asymptomatic, once she attains menopause, I will ask her to come. If she is asymptomatic, she is not having any hot flushes or any urogenitary symptoms. Usually we don't start, ma'am. If she is symptomatic only, we start on replacement therapy.
Now, at present, what will you tell her? You have to assure her first.
At present, we should tell once the periods is regular, you need not worry about the menopause.
Yes,
so
that is
once
the thing we have to
talk, you have to come and meet me.
Okay,
once
that's very, very important. Okay,
so once there is delayed period for 6 months,
even if there are no symptoms, better she comes to us so that we can have a thorough checkup. Okay. Now, this is another patient. She is 48-year-old. She has attained menopause 2 years ago. Now, maybe again you take, she is not symptomatic. She is a beautician and just sitting in the AC room and doing all this work in the beauty clinic. And she has her main concern is that she has got growing more coarse hair on the upper lip and chin since the time of menopause, and she is also gaining more weight, especially around the waist and the hips. Now, what will you do? When she doesn't have any symptom, what will you do? If she comes with the hot flushes, what will you do? She has attained menopause, but her main concern is obesity and this mild.
For her, she has to have a lifestyle modification only, ma'am. At present.
Okay.
She has no symptoms of menopause, like no hot flushes.
As a beautician, she is always looking only at the face, I believe, not about exercise and all.
So she has to start some physical activity. She has to be on a diet, and then we'll just wait and watch and then see whether she's developing any symptoms. And that's the thing we can suggest to her.
Okay, then lifestyle, and once she becomes asymptomatic, we can give her supplements. At the same time, take this opportunity to do the screening test also, not only gynecological, other screening tests also. She is obese, diabetes, and other things. Okay,
thyroid, diabetes.
This is another point I want to stress all the practicing gynecologists, that whenever a woman comes around menopause with some other problem, don't just look at that only. Now, grab that opportunity to do other screening tests also, because many women, they do not come forward for any screening test on their own. So at this time, at least you catch hold of them and do the other screening tests also. This is the point I want to stress. And if she comes with symptoms, of course, you can go for a hormone therapy. How we are going to start it, we will discuss when we are talking about the other symptoms. Now, this is another patient, 44-year-old, not attained menopause, and she has come with hot flashes. She is again hypothyroid and thyroxine for the past 12 years. She gives a history. Now, history is very, very important, family history also. Okay. Now, her sister had a hip fracture at the age of 54. Now, the patient's BMI is only 18. Now, what is her main risk? What investigations you prefer to do, and how are you going to manage her?
Padma madam has joined, madam.
Padma, can it say?
Good evening, madam. Yes.
Yeah, now audible.
Yeah.
Apart from the routine investigations, routine health investigations like hemoglobin, all the thyroid and
Thyroid, she is already on thyroxine.
Diabetic screening, I will advise a DEXA scan because she her family history has, her sister had a fracture at 54, but and her BMI is slightly less. So
yes,
so I would prefer to do a DEXA scan first.
Okay, the DEXA shows like this: osteopenia.
Osteopenia.
What next?
I will advise her first lifestyle modifications like regular exercises. Vitamin, I'll take care of her vitamin D deficiency and calcium, and I will advise her to do strength training.
Exactly. Exercise. Because osteopenia has got twofold increase in fracture compared to normal, and all the more she has got a family history also. Once osteoporosis sets in, there are even higher risk of fracture also. Now, this patient, she has already got hot flashes also. So, would you prefer a hormone therapy for her?
Yes.
Yes.
Hormone therapy. Now, you have to look for any contraindication, and then you have to definitely opt for a hormone therapy. Okay, that is another thing. And again, in perimenopause and postmenopause, which type of MSG we'll discuss in the next case. And again, this is another point. How many of you agree with me? Women of less than 60 years, when there is increased risk of fracture, like family history, osteopenia, hormone therapy is appropriate first-line therapy. How many would like to start?
Risk fracture, if we have to start early, now as early as 2 to 5 years by within period of menopause. But actually,
no,
when
this
we have
patient is just 44, only family history of fracture, and she herself has got osteopenia.
So lifestyle modification as well as with the calcium and vitamin D3 would help. Rather than starting with the patient not attained menopause, starting them on.
If the patient wishes, we can start. It is individualized treatment, madam.
Exactly.
So if the patient wants, we can start her. We can explain all the consequences and start her on menopause hormone therapy.
Exactly. See, I have just, my son-in-law himself is an orthopedician, and I have discussed with many orthopedicians also. They all opt for only non-hormonal therapy, like bisphosphonates and other things, if at all they find any problem with this bone. Whereas we gynecologists always prefer a hormone, provided there are no contraindications, and we just counsel the patients also on that. Okay. Now, this is another patient, 50-year-old, and she has undergone THBSO for endometriosis two months ago. Okay. And now she presents with hot flashes since 1 month. Some gynecologists, that is a person who did the surgery, they just asked her to take this alternative, as Radha said. Take soya, take tofu, this, that, and all. But there is absolutely no relief, and she has come for a second opinion. Clinically, everything is normal. No other risk factor, everything is normal. Now, how are you going to manage her? Will you prefer to give MSG for this patient? She has undergone surgery for endometriosis.
Yes, I will prefer.
Would you like to give estrogen?
Some we can give.
What, Shanma, would you tell me?
We can give raloxifene or SCRM, we can give, ma'am.
For hot flashes, which is the best one?
Estrogen progesterone combination.
But she has undergone endometriotic surgery 2 months back.
Okay.
So,
estrogen progesterone combination.
Estrogen alone would you like to give, or estrogen progesterone combination you would like to give, or any other alternative you want to give?
Estrogen progesterone combination, and the progesterone will be Dynogest.
Very good. That's good. That's good. Now, this point again, I want to stress that just because she has had an endometriosis earlier and surgery done, doesn't mean that you can totally rule out the possibility of using estrogen, you can combine it with progesterone and then give. Okay. But otherwise, now it has been shown, no, in women with surgically induced menopause after endometriosis, or even a natural menopause because of endometriosis, estrogen progesterone combination or tibolone can be effective for the treatment of menopausal symptoms. Okay, this is another thing. Now, suppose a woman has undergone hysterectomy and she has come with the symptoms. Okay, now which one do you prefer, estrogen alone or estrogen progesterone therapy?
After hysterectomy, we prefer estrogen, madam. Progesterone only to prevent the action of hyperestrogenism and endometrial malignancy, fear of endometrial malignancy. But once the uterus is out, we can give only estrogen. There's no need for progesterone.
Okay, so estrogen alone is good enough, but in case of endometriosis, this is the only area, and it is done for endometriosis. Of course, you have to combine it with progesterone, okay? Progesterone combination, right? And suppose a patient has undergone hysterectomy for stage 1 or 2 adenocarcinoma of the endometrium, and she has come with a symptom. Now, these are all the things we are talking about only when they come with the symptoms, not otherwise. Okay.
So then progesterone we can add.
This also you can give estrogen. Agreed?
Adenocarcinoma.
Estrogen dependent malignancy.
Now here again you can go for estrogen progesterone combination, and there is no fear of recurrence. It has been proved in various studies also. And again, it has been shown that previously treated endometrioid carcinoma of the ovary, when they come with the symptom, again you can go for estrogen progesterone combination, and it is not going to cause any complication or recurrence of the malignancy. Okay. And another point is that suppose that after surgical menopause in postmenopausal women, for prevention of chronic conditions, now hormone therapy is not advised. Okay, it's clear. Only the surgical menopause in women less than 50 years, you have to go for hormone therapy, right? Now, this is another patient, 51-year-old. She has had a menopause, last menstrual period 14 months ago. Okay, 1 year gone. And she has got hot flushes and sweats and mood swings. And also she is feeling tired, she is gaining weight. All these things put together made her quality of life very, very poor. But remember, she has never undergone any surgery. Her uterus is still there. Now, no other significant family or personal history, and he has come with all the symptoms. With the uterus intact, what is your management? Pardon?
Menopause hormone therapy.
Now, this is a post-menopausal woman with the symptoms with the intact uterus. Which one will you prefer? Estrogen progesterone continuous combined, estrogen progesterone sequential, oral estrogen alone, or combined OCP or isoflavones? Radha, what will you prefer?
Estrogen progesterone continuous combined therapy.
Okay, all of you agree?
Yes, ma'am.
Radha has come to our line. No isoflavone or no alternate, nothing like that.
Just for we should try those things and then you should convince them.
No. Why try and see? Straight away you can go for it. Okay, that's good. Suppose it's the same thing like in a perimenopause. Now this is the patient, 48-year-old, not yet attained menopause. Now she's having irregular cycles. The same symptoms she has got. Her uterus is intact now and no other complications, no personal or family history. So this is perimenopausal with the same symptoms. What will you do?
We can go for a sequential therapy, ma'am. Oral estrogen progesterone sequential therapy.
Okay. Why don't you go for
tibolone?
Padma, why don't you go for tibolone or combined OC pills? Padma. She has got come with the symptoms and she has got irregular bleeding also. Of course, obviously nobody will go for estrogen alone. Can you prefer OCP or tibolone? Padma, are you there?
Yes, she is there, madam. Mathirippi, mic is muted.
Hello, madam.
Tell me, Padma.
A lower dose of OC pills we can actually start. Low dose OC pills. Madam, her age I didn't get.
48.
Low dose OC pills we can start.
Now, the first preference is only estrogen progesterone sequential therapy, because when she comes with the symptoms, the dose that we give in this OC pills is not going to support that. Okay, yes, so that is preferable. Or as she said, you can even go for tibolone. But first preference is only sequential therapy. Now, how is this hormone history, menopause hormone therapy given? What are all the combinations by which you give that? The three important things.
Oral, vaginal, and transdermal.
Not there.
And oral route, vaginal route, transdermal applications.
That is route, sir. Now oral route, now how are you going to do?
Generally, we
come with the symptoms. Like vasomotor symptoms has come. When there is no uterus, you go for a continuous estrogen therapy.
Estrogen therapy.
Okay. And if it is perimenopausal, you go for a continuous sequential. And if it is postmenopausal, you have to go for a continuous combined. Because postmenopausal, you don't want her to bleed anymore. So you have to go for a continuous combined therapy. Okay. Now, which estrogen do you prefer? There are 17-beta estradiol, estradiol valerate, conjugated equine estrogen, or synthetic estradiol, ethinyl estradiol.
Conjugated equine estradiol is preferred.
Mostly available is conjugated equine estradiol, ma'am.
But which one is better?
Actually, 17-beta estradiol is better because it's more, it is identical to other estrogen.
Natural.
Yes, 17-beta estradiol is the best one, okay, better one than CEE, because it is even safer than the synthetic counterpart, and it is convenient for oral administration. And compared to CEE, lot of advantages are there with 17-beta estradiol. Okay, like mammographic density, blood pressure, coagulation factor effects. All these effects are little higher with the conjugated ethinyl estrogen compared to estradiol valerate. So you prefer 17-beta estradiol. Okay, progesterone, which one do you prefer? Which progesterone? And one point already Padma told.
Micronized progesterone is better, ma'am.
Or LNG.
Or metroxyprogesterone.
Metroxyprogesterone you prefer? MPA?
Ma'am, sorry.
Dihydrogesterone.
Why not MPA?
Risk of
endometrial hyperplasia.
No, CA breast.
Exactly. See, this MPA was the culprit in WHO study. That is why we switched over to the other type of progesterone. Okay, we always prefer either a micronized progesterone or you go for a dihydrogesterone. Okay, that is a better option. Now, why you give this progesterone always when the uterus is there? Mainly for
endometrial hyperplasia.
Counteract the effect of the estrogen on endometrium, hyperplasia and cancer. Okay, and non-androgenic forms like dihydrogesterone is the preferred one. And androgenic progesterone like MPA, we don't prefer. Okay. And Mirena, of course, okay, fine. Drospirenone also, we can combine. Okay. Can anyone tell something about Tibolone? We are talking all the time. Tibolone can also be given.
Tibolone is a selective estrogen receptor modulator, and it has got a weak estrogenic and progesteronic activity, also androgenic activity. It selectively acts on the receptor, and it is definitely an effective, in my opinion.
Okay. Why we are not using it so commonly as before?
Only for vasomotor.
I have used it for all the surgical menopause. They have sudden vasomotor symptoms.
Yes.
So it's very effective if they use it for
I
6
myself,
cycles.
I have taken Tibolone after hysterectomy with BSO, and I was comfortable with that. Okay, that is the thing. And
mood elevation and all, it's very useful. The depression and all, they'll not.
So estrogenic, specifically, it has got selective action on various areas. Estrogenic action only on bone, vagina, and vasomotor symptoms. Progesterogenic and anti-estrogenic action on endometrium and breast, and androgenic action on mood and libido. Okay, so that is the thing. Yes. Now, combination of 17-beta estradiol and dihydrogesterone is available now. I hope all of you are aware of that.
Femostone.
Now, this is available both as a sequential MSG and continuous combined MSG. Okay, as you can see here very clearly, first half the 17-beta estradiol and second half combination of estradiol and dihydrogesterone, whereas continuous combined, all tablets contain both 17-beta estradiol and dihydrogesterone. And this is very, very helpful because in perimenopause, you go for 1 milligram estradiol plus 10 milligram dihydro as a sequential therapy. And post-menopause, even a lesser dose of progesterone is okay. 1 milligram estradiol with 5 milligram dihydrogesterone, continuous combined. And remember one important thing, that in premature ovarian insufficiency or surgical menopause, we have to give a higher dosage because we have to compensate the loss. Okay, so to go for a 2 milligram estrogen plus, of course, 10 milligram dihydrogesterone. Okay, this point we have to remember, and the availability of this as Femostone is also to be known. Okay, now this is another patient. She is 55-year-old, presents with She has got a lot of treatment, antibiotic and other things for vaginal irritation, urogenital itching and all. And obviously every time then 55-year-old coming with itching vulva, you go for a diabetic screening, and she was found to have normal glucose screening test. Okay, but she had dyslipidemia, BMI is 35 and menopause 3 years ago. And on examination, vaginal walls are dry and atrophic like this. How are you going to manage this?
Local
Local
estrogen.
estrogen, ma'am.
Okay, straight away you go for local estrogen, or
Yeah, for her, she's on the obese side.
Dyslipidemic.
see, never jump to treat the symptoms. Treat the patient totally. This patient is 55-year-old, dyslipidemia, BMI is high. So you have to assess the risk for cardiac disease also, right? That is very, very important. That is an important point. Any gynecologist, especially gynecologist, the menopause clinic, don't focus only on the menopause and the menopause symptoms, but also the overall health of the patient. Okay, that is very, very important. So you can advise her therapeutic lifestyle management and treat the dyslipidemia also. And vaginal estrogens, as everyone rightly said, you have to give that. And you can go for lubricants and for
when needed.
Improvement. Okay. And now, Radha, have you ever tried this lubricants and other things, succeeded in treating this vaginal irritation?
Before she comes with this stage, I would have advised her to use earlier itself lubricants regularly, so that this is where almost the vagina has got cicatrized. It's impossible for her to have anything of a sex life. So she will be going into, as it is obese and dyslipidemic, she'll become depressed in no time. Earlier itself, we could have tried lubricants, lifestyle modification. Now she has come at this stage. In addition to vaginal estrogen, if she is all the other parameters are okay, even 1 or 2 cycles of MHT also might be needed for her. Systemic
Exactly.
also.
How many of you agree with Radha that straight away you go for, I mean, only first line is lubricants, or straight away first line estrogen you are going to give, local estrogen? How many of you vote for local estrogen as the first line?
Ma'am, I usually go for local estrogen.
Local estrogen, madam. But many
Why,
a time,
why?
Not proven to be beneficial most of the times.
Exactly.
Right.
And once the atrophic changes already occurred, subsequently later on, if you are going to give the estrogen, it is not going to have any improvement at all. Okay, that is very, very important. Now, this patient with the dyslipidemia, are there other alternatives? Suppose if she has not come for a vaginal problem, if she has come for another symptom like hot flushes.
Yes, transdermal HT is preferred because that first pass effect and
Exactly.
the dose
This
required
is
is
the
less.
thing. So you have to know the symptom for which she has come, associated comorbid conditions. So what you can give, okay, that is another thing. And even in venous thromboembolism history, you can, vaginal hormone therapy can be given if she has come for a vaginal symptom, urogenital symptom, okay, and this is not going to affect the problem of BPE, right? Now, what are all the things included under GSM? We talk a lot about GSM.
Dry vagina, increased frequency, increased dysuria.
Recurrent urinary tract infections.
Exactly.
Actually, they have been going from pillar to post for treating this UTI, madam. So, but without any use. So they have been given so many antibiotics. So I think this.
So many antibiotics, probiotics, this, that, and all, and again they are not at all relieved. Okay. Now you have to remember the group of symptoms in GSM, so that when the patients come with these symptoms, you have to identify this as GSM, so that we can treat them properly. Okay, that is very, very important. What did you say, Manonmani?
Madam, this awareness should be there because many times they go to so many places and taking so many cultures and so much of antibiotics. But only thing is none of them identify it as, unless otherwise they come to gynecologist, they are not identifying it as a GSM. So
they would have drank bottles of cranberry juice by now.
Exactly. So vaginal hormone therapy rather has got so many advantages. It is best treated originator. And ECG is easily absorbed through the atrophic vaginal epithelium, and it is very, very, this point I want to stress, very important to start the treatment early before any irreversible atrophic changes settles. Okay, that is very, very important. The doses. Chocolate. Dose of estrogen. Rather.
Standard doses conjugate equine estrogen 0.3 to 2.5 milligram per day.
Primarily.
25 microgram per day. Estriol cream 0.5 milligram per day. Estriol tablets 48 milligram for 2 weeks followed by maintenance therapy. Low dose is very effective. Ultra low dose vaginal estradiol also found in this thing. It increases vaginal maturation, improves vaginal health, restores vaginal pH, and decreases vaginal symptoms. The only thing I would want to add here, madam, or they should investigate their husbands for candidiasis and all those things also.
Obviously, that is additional. Okay. And just like oral estrogen, we start with the low dose and then step it up, tailor it according to the patient. Here also low dose works out very well. This is the point which everyone should know. And which form is the best of vaginal estrogen? Cream, gel, ring, or tablet?
Gel.
Which you prefer?
Tablet is the best.
Why?
Because it is 17B estradiol, so that is the best. But routinely we give the topical estrogens, cream.
Because as far outcome is concerned, all are same. They just differ slightly in their side effects, but also complaints. Okay.
Tablet every day we get the same dose, madam. Ointment sometimes they'll apply more, sometimes overdosing or underdosing occurs. So tablet is good.
Now there are some advances in vaginal estrogen in that the bioadhesive formulas. They are also available to keep the correct dose of estrogen in place for a longer time. Okay, bioadhesive formulations, right? Now, when you give vaginal estrogen, should we need to do an endometrial surveillance regularly?
Not required unless patient has any symptoms.
Any chance of endometrial carcinoma or hyperplasia developing?
We should have baseline ultrasound and the endometrial lining, the thing. That is ideal.
But subsequently, follow up, should we?
It is only
Follow-up
locally
should be
active.
done.
No need, isn't it? Rarely they have given us for using for 10 years and all. They have rarely 1 or 2 cases reported as endometrial carcinoma. But remember one thing: we are not going to give it for such a long time. First of all,
6 months,
okay, not more than 1 year or 6 months. We are going to give during that time with that dosage. Absolutely no chance of endometrial hyperplasia or chance of endometrial carcinoma. So there is no need for endometrial surveillance and no need for progesterone supplementation also. So as per Cochrane review, in the prescribed dose and duration, this vaginal estrogen, there is no incidence of hyperplasia even after 6 to 24 months of use. Okay. Now, suppose breast carcinoma patient, breast carcinoma survivors, they come with the hot flashes. What will you do?
I will not prescribe HRT. No.
Huh?
No HRT.
No HRT. What to do? So no systemic estrogen or progesterone. Now comes Radha's alternative therapy. No other.
BRCA gene.
BRCA gene can also take MST.
I just wanted to tell that.
Yeah, BRCA gene, they can take MST. But if it is for hot flashes, you can go for SSRI, paraxetine 7.5 milligram. And if it is for GSM, you can go for a local estrogen.
Even tender loving care, TLC also is very effective, madam.
Okay, that holds good in both obstetrics, RPL as well as here also. Menopausal women also. Okay, it's always there. Now this is the Femostone. You have got various dosage for peri and post-menopausal.
Finish by 5:45.
Okay, sure. Just 5 minutes. Okay. Now, can anyone tell something about the transdermal estrogen? We have got both patches as well as spray. Okay. Now, the advantage of transdermal is that this has got a very, very minimal systemic side effect. Okay, that is very important, but a little costly. But you have got this. Have you heard of that Lenzetto transdermal spray? It is not yet available in India, but it will come soon. It is a very novel delivery system of estradiol, and you can just give it just like an injection. Okay, you can just give this transdermal spray also. Now, okay, we have given the MST. How are you going to follow them up? How frequently are you going to ask her to come for follow up? Dr. Lakshmi?
Ma'am, initially I would like to call her up after 3 months to see how she's doing. Then follow up that.
Just for after 1 month itself, you know the efficacy, side effect, weight checkup, and BP and all. After 3 months, to assess the effect as well as complaints. And then
Annually, every year, ma'am, and with a routine physical examination and basic blood test and imaging that is required.
Okay, okay. And every time she comes, you have to look at her general things also. Like if suppose she develops jaundice or a significant rise in blood pressure or migraine appears for the first time, or already what she has got headache, it is getting worsened, you have to stop that.
Stop the treatment.
Okay. Now, quick, everyone can, one by one, you can answer that. Suppose she comes with the persistent vasomotor symptom, what will you do?
We can change the dose.
Okay, yes, yes. You can little increase or change another thing. Suppose she comes with the breast tenderness.
Reduce
the estrogen dose.
And also progesterone also you can change other thing. Suppose she comes with an unscheduled bleeding within the first 3 months.
We have
Always
to
rule out malignancy.
No, it is normal within the first 3 months usually to have a.
Now this is the point again you have to learn. Within first 3 months, if she comes with unscheduled bleeding, don't worry about it. You continue the treatment unless there is a high suspicion that she may have an endometrial carcinoma. Otherwise, you can just wait. Okay. Or you can switch over if she is already on continuous, you can switch over to cyclical or something like that. Okay. Suppose if it is after 6 months, 3 to 6 months, then the question comes. So you have to look for that, do further investigations and look for endometrial carcinoma. And as the history we have to ask, but taking any other medications, what are the possibility of interaction with other drugs?
Anti-epileptics.
Yes.
And
anti-tuberculous, okay, and even hormone therapy increase the level of thyroid binding globulin. So these points also you should keep in mind. So before we conclude, our aim of management is generally the management to depend upon the symptom relief. You have to identify the comorbid conditions, lifestyle of the patient, socioeconomic status, and acceptance. Okay, and give tender loving care. And menopause treatment and management revolve around minimizing the disruptive symptoms, and at the same not only symptom relief, but also you have to look at the prevention of long-term complications also. And always we have to do a risk-benefit analysis, individualize the treatment, and treating for menopause gives an opportunity for you to treat other diseases also. To put it in nutshell, surgical menopause, estrogen only or tibolone, perimenopause, cyclical or preferably even sequential. Cyclical we are not going nowadays. And menopausal and postmenopausal continuous combined or tibolone. Premature menopause, sequential MST, of course rarely OCP also. And urogenital atrophy, local estrogens. And women age less than 50, benefits of HRT are far outweighing. And 50 to 60, okay, you can give. After 60, the benefits are equal. You have to choose and then give. After 70, no. Okay. So if you choose the right woman, choose the right age, that is less than 60 and within 10 years of menopause, and right hormone, which hormone to choose, what is the dose to use and all, and the route also. Suppose the patient has got some complication, don't think that you cannot give hormone. Route matte. So identify the route. You can go for a transdermal or you can go for some vaginal. So depending upon the associated comorbidities, you can choose the route, and making all these things correctly, you can give the right treatment of MST to our patients so that they will get the benefit. So our aim of TNFOG is that we want to give quality of life to women right from womb to doom. Okay, so we have to give them quality life, especially in menopause. If you have an idea about the menopause changes, symptoms, and the management with the hormone therapy, which all of our panelists have discussed very nicely, definitely we can give them a quality life. I thank all my panelists for giving their wonderful inputs about MST. Thank you very much.
Thank you, madam.
Thank you, madam. Thank you, madam, for giving me.
Thank you, Revati, ma'am. Thank you, everybody.
Thank you, ma'am.
Thank you, Tnfog, and Tnfog, we are happy to be the part of the first panel to start with your.
Thank you. We expect cooperation from all of you in future work also.
Thank you.
Thank you.
Thank you, Revati, madam. Fantastic panel and a good discussion by our panelists. Now I will we'll go to the question session. Delegates, the questions will be. Sugashri, 1 minute. Sahiti, you can post the question on panel for the winner.
But Sambat, can you put me in? Sambat, can you put me in? I have to leave IOG.
Yes.
That is what.
Then Jairani will be held up with IOG. Sahiti, if you put the question, then Jairani will start her talk.
Okay, ma'am. Okay, ma'am.
Put the question of menopausal hormone therapy. Then Dr. Mary can introduce Jairani after this question session.
Okay, ma'am. Ma'am, shall I launch the question, ma'am?
Yes, second question, sir.
Okay, ma'am.
Final question, you launch it. Dear delegates, please answer this question.
Yes, ma'am. Ma'am, what's the time limit, ma'am?
Yes, we can see. Delegates, can you see the question?
Yes.
Drugs used in panelists cannot answer. The questions is only for delegates, not for faculty. Drugs used in MHT except estrogen, raloxifene, kibolan, and armiloxifene.
$20 seconds over.
Yes, 60 seconds you can allow.
Okay, ma'am. $30 seconds over. Last 10 seconds.
Yes.
Time.
Thank you. Sakiti, you can put a result after Jairani's talk.
Okay, ma'am. Okay, ma'am.
I requested Dr. Mary to introduce Dr. Jairani. Jairani, TV.
Can you allow me to share the screen, Shanti?
Mary Annie, are you there? Saravana Kumar?
Yes, ma'am. Mariani ma'am has joined, ma'am.
Has joined, but she is not there. Dr. Mary? So it's a pleasure to introduce Dr. Jairani. I myself is introduced.
Shall I introduce?
Yes, Saravana Kumar. Yes, you can introduce.
So our Madam Dr. Jairani is well known to all of us. She is the Senior Infertility Specialist Director, Akash Fertility Center and Hospital, Chennai. She is the Vice President of Oxy. And Madam, she is going to become the President of Oxy. There is a, okay, I saw the flyer there. She is going to take over as the President of Oxy. Her medals and awards are Best Doctor Award by MGR University, Chennai. Rajamani Janakiraman University, first prize in Gynecology and Obstetrics. Vadamalayan Endowment Gold Medalist in MBBS Obstetrics and Gynecology Examination. Anandachari Prize for being the University first in Medicine Gold Medal in DGO. And awarded the Women of the Year 2010 by Lions Club. Achievement of Human Service by Exnora. Mega TV Women Achiever Award in 2011. Nalam Hospital Women Achiever Award in 2011. And Best Private Pair Award for Sexual Dysfunction PCOS Women. Over to you, Madam. Actually, we are not practicing infertility as a specialty, but we all know the stress involved in managing infertility patients, especially 1 or 2 letrozole failure cases. When they come, we have to sit with them and counsel a lot towards them. So you please explain us how we are doing the
Though not infertility specialist, the counseling part is best done by the practitioners. That is like a family practice doctors.
I agree with ma'am. அனைவருக்கும் மாலை வணக்கம். சென்னையிலிருந்து புயலோடு நாங்க வந்து டிஎன்எஃப்ஓஜியோட மராத்தான்ல இணைவதில் அன்பு மகிழ்ச்சி. Thank you, Chairperson. Thank you, Saravanan sir, for giving that introduction, nice introduction. And my special thanks to my mentor, Dr. Revathi Madam, and my dear friend Sampath, and all the TNFOG presidents here. It is really amazing to have a marathon CME, and I really appreciate the Sampath spirit of having a wonderful, very energetic way of handling everything in her way. That is a really amazing thing in Sampath, which I really appreciate. Sampath, thank you for making me a part of this wonderful CME to start with. So I would be very happy to talk about the stress and infertility. So as rightly pointed out by my chairperson, that stress, when a couple comes with infertility, the stress in them is mammoth. There are a lot of doubts about whether the stress causes infertility or because of the infertility, they have the stress. This is a big question exists among both the physicians, both the consultants, both the patients, and also about all the public who are around the patient. So there is a big question that whether stress causes infertility or infertility is a result of stress. So if you look into the stress, we all know stress is something, an event or anything which makes people to feel frightened or threatened, and the body responds in a different way, either in the fight or flight response. That we all know as a practitioner. So any disease, if it is having a stress will have this type of response. And even fertility also has a role of it. So when an infertility diagnosed, how a couple feels, that is what the big question. And a very big research says that a couple feels that they've been diagnosed like a cancer. So that is the most saddest point, that a physiologically enabling thing, which is a normal physiology of a reproduction, when it fails because of some reason, they face a situation of a stress like a cancer being diagnosed. That is what the couple feels, both the men and the women. So that is how the infertility diagnosis even makes a couple feels. So definitely this stress of infertility, both as a cause and effect, is definitely has to be very clearly thought in a clinical practice. So when I look into the stress, there are two things I could see in a stress. One is a negative stress. A negative stress, for example, a pressure of bill, or starting a job, or caring for a sick relative. This is what they say as a negative stress or a distress. Whereas a good stress, there are some good stress also. For example, you're getting married or planning to move towards a new home, or winning a lottery. That also is a very good feel. That is also a positive stress or a eustress. How this infertility is looked into it. The infertility is frequently seen as a distress category, because we have to look into the lot of medical procedures that they have to undergo, the economical cost involved, and not sure of the consequence, or not sure of the outcome. That is a very important one. And all the more of this unwanted, unhelpful advice from friends, criticism, relatives, stress, and all the expectations, anxiety, everything put a woman or a couple, when they're diagnosed as an infertility, it is like a distress. And this belongs to a distress category. That is why infertility has a cause and an effect way. And definitely there needs a lot of studies to substantiate whether there is how this infertility is related to stress, and stress is related to infertility. Really, it is still a very big category to be really looked into it. So the very big question, which causes what is the cause or the consequences, that is very important. Whether this is a cause or the effect of infertility is real question. And whether the stress will be reduced can enhance a pregnancy is also a big question. So when you see a couple very much stressed and say, okay, stress is your problem, and if you give them a treatment for the stress, will it improve the pregnancy when she gets a pregnancy? That's a big question. So everything has to be really looked into it when you look into a patient with infertility. And definitely stress causing an infertility and cause and effect is still a controversial. So is there any biological connection? That is the next step, that as a scientific content and as a scientific seeing with, doctors, what we look at is what's the biological connection with a stress. How this biological emotional stress can lead to a biological effect, which can impact the fertility of this women. So there comes our hypothalamo-pituitary adrenal axis. We all know whenever a body perceives a stress, the hypothalamus gland is the one which signals to the pituitary that is under a stress. The signal indicates that this is under stress and it needs an assistance. The pituitary reacts to this call by sending its own hormones to the adrenals. That will cause a release in the stress hormone, that is the cortisol. We all know this is a pathway. Whenever a stress triggers, the hypothalamo-pituitary ovarian axis affects the release of the cortisol. Cortisol is good. That is a response which is good, appreciated, because that gives a response to face it, to react to it, either by various emotions. But at the same time, it can cause a lot of metabolic changes in us, in causing a lot of sugar increasing, and also some changes in the hormones, which may harm a health in long term. Because you know, this infertility is not one day or a 1 week. It is a chronic problem. A chronic infertility cause a chronic stress, and that chronic stress will lead on to a problem, which is definitely has to be addressed and definitely has to be controlled. So this hypothalamo-pituitary ovarian hormones, they not only regulate the hormones, but they also have an effect on the other hormones. It not only releases the cortisol, but it also acts on the pituitary to release the GnRH, gonadotropin releasing hormone, which may have an effect on the gonadotrophins, that is an FSH and LH, and that is very essential for this ovulation. We all know that the ovulation FSH LH is needed. So when there is a stress, this pituitary and the hypothalamus interplay to have an effect on these hormones, and that produce a hormonal changes, and that effect will be there on the fertility treatment as well as the infertility. So we all know this hypothalamus regulates the sex hormones. Excessive stress may lead to a complete suppression of the menstrual cycle. And this is often seen in a female marathon runner who develop a sudden amenorrhea, because when they do a lot of exercise, when they go for a stress, this can even cause a amenorrhea, mainly because of the suppression of these hormones. In very severe, less severe cases, it may go for an anovulation. That is why if you see a girl, when she gets married, if she goes into the family, she gets very stressed out. Till the time her periods will be regular. But once she enters into a married life and going to a new home, the periods will get irregular. Same way, when a girl go to the hostel or get into a new job, the emotional stress has the greatest impact by the hypothalamus pituitary ovarian axis changes, and that will cause a lot of problem in the ovulation, leading on to irregular ovulation, and also causing an increase in all the hormones, like variations in the balance of the LH-FSH, increase in the amounts of the prolactin, and that will cause an impact in the fertility outcome, especially by the ovulation disturbances. And second is the catecholamine receptors. This receptors also has a potential effect on the fertility. This will interfere in the transport of the gametes through the fallopian tubes. So when the women get stressed and anxious, her catecholamines will act on the smooth muscles, and that will cause a spasm, and that will cause an impediment in the tubal transfer of the gametes and affecting her fertility. And second, it also affects on the immune system, because when you are stressed, there are a lot of neuropeptides which are released in response to the emotions. This neuropeptides acts on the immunological system, and thereby the mind and body, though they are not extremely connected by the immune system, they may have a negative influence on the fertility, mainly by affecting their immunological system. So if you put into a nice pictures, that picture explanation for the stress and infertility, if you look into it, it have an effect on the hormones by the hypothalamus pituitary ovarian axis, causing an alteration in the hormones of your LH, FSH, and prolactin, and that affects the menstrual irregularities, causing an oligo-ovulation and anovulation, and also have an effect on the adrenal and thyroid, and thereby causing an effect on the cortisol level, and thereby affecting their fertility, and also causing a catecholamines, which causes an effect on the smooth muscles of the fallopian tubes, causing a tubal spasm, on the cervix, causing a cervical tightening, and also it causes even a vagina, causing a vaginismus also. So in addition, it also affects the glandular response by causing an effect on the cervical mucus secretion, and the immunological problem causing antibodies which can prevent the sperm from entry, causing the anti-sperm antibodies also. So all these effects of the stress causing a various effects on the fertility outcome. So definitely there is a biological role of this chronic stress of infertility affecting the women, and thereby affecting her fertility outcome, as well as causes an infertility also. So what the evidence is, because we always practice evidence-based medicine, and what the evidence is, because many times we cannot find out any proper questionnaire to ask a women whether they have stress, whether they are very stressed, and how to measure this stress. It is still a question, because some women, even with a lot of stress, they will show a sweet face. They will mask their emotions. They will mask their anxiety, and they will try to be there, because many factors play a role. There are a lot of factors: your social, your emotional, your environmental, your education, your career, your studies, your vision, everything plays a role, and your esteem, your image, everything have a role in this when they get stressed of the infertility, because it is a normal physiology. They are not diseased. They are very normal. The couple are normal. So in that way, how to find out whether they are really stressed and whether this has an impact? So there are a lot of studies which has been done in UK, where they have studied the alpha amylase of the saliva. They remove the they assess test the levels of the alpha amylase, the hormone which is very important for the stress. So during the ovulatory period, women who are undergoing fertility treatment, and they have studied that alpha amylase level, what they have found out is the women with a higher concentration of alpha amylase took longer time to get pregnant when compared to the women, those with a lower level of these hormones. So definitely alpha amylase is more in a stressful women, and they have a difficulty in conceiving. And also another level, the cortisol level. When the cortisol level is also increased, they have a longer time to get a pregnancy than those with a lower levels. So these connections, though it's unclear, but they proved that definitely the women who are stressed will have an effect on their outcome. So that is a very important study. And second, there is one more study in the Michigan, Texas studies where they also investigated the hormone amylase and cortisol in saliva. They've also found out the same answer, that the women who have a highest level of this hormone, nearly around 40% of the women, they have the time to pregnancy is very prolonged, whereas in 29% where there is a lower level have a better pregnancy outcome as well as a pregnancy related. So definitely there is a effect on the stress and the hormone changes, which is impact on their fertility outcome. Next, related to the socioeconomic stress. If a couple is very poor or socioeconomically, they need an ART procedure, how this impact on the fertility outcome. So definitely they also says that it affects negatively on the fertility. So when they really want to pursue a treatment for ART and they don't have proper money, that stress make them much more poor in their outcome. They're very anxious, they're more stressed, they're more depressed, and that makes them less chances to get a success in the ART. That's what they say. And there has been some study which said that couple who had gone for a treatment with an insurance or loan or some money which they have a better fertility rather than people who have a low socioeconomic status. When they are more stressed, their pregnancy outcome is, and also the fertility treatment outcome is very much lowered. So economic stress play a very important role in the fertility treatment outcome, and people who have more this economic constraint has a lesser chances to conceive. And when you look into the male fertility also is definitely affected by the stress. A meta-analysis of the 57 different studies, which included nearly around 30,000 men found that the psychological stress could lower their sperm concentration, sperm motility, as well as the abnormality in the sperm shapes. So this has been proved by this study. Another study is the 2 stressful events where there is a semen analysis falling below the normal, whatever the guidelines given by the WHO, what they have found out that they have a stressful collection, have a very poor count. So that is also very important. And also the testosterone levels is lower when a men experience psychological stress, though it is difficult to know what comes first and what is an effect, but definitely there is some effect on the testosterone level in the male fertility also. So in this way, what they have concluded in many of the studies is stress doesn't have a direct impact on the fertility, but it also have an effect on the success rate. Because they have studied IVF ART undergoing couple, what they have found out is they don't have exactly the treatment outcome, but what they found out is many of them, because of the stress, they stopped the treatment. That is an interesting fact they found out, because they could not cope up with the stress of the treatment process. So they stopped. That is the important part they found out. Many couples drop out of the treatment prematurely, mainly because of the emotional distress. That is what they feel when they undergo an advanced ART procedures. So even they have found out in one study, they have found in some country where they have a healthcare funding where the patient won't pay from their pocket. Even in that couple, even in that group of couple, 40% they dropped after the first cycle of failure, though they have been enough counseling that it should be, the success can come only with the repeated attempts, but still there is a dropout of 40% because the emotional stress they go through when their treatment is there, that have an impact on the outcome of the fertility also. People who are much relaxed, much less stressed, have a pregnancy better than a couple who are very much stressed. And some studies have a conflicting evidence. The emotional doesn't have any effect on the IVF success. That's what they said. But there are also a lot of factors which plays other role, like their other socioeconomic status, family support, parental support, and husband-wife relationships. Everything play a role. So still there is no substantial evidence to say that the infertility stress, how it is linked and how it can be treated. Very interestingly, I want to say, as a as a center where we practice both sexual medicine and fertility medicine, we have a problem which is very much important in the infertile couple is the sexual issues. The sex becomes a stressful one. The sex focus towards procreation. So that is a very important step which fails in the infertile couple, because when you ask them about the sexual history, many of them say, we have sex around the ovulation. When the doctor says that they have the ovulatory follicular tracking, but they don't have a very proper sexual intercourse, mainly what is supposed to be the need for the fertility, which is not happening in the infertile couple, mainly because of the stress. So it is mainly because the practice of the sexual function has been affected by the infertility, has been proved with many studies, because they always insist on the frequency in the mid-cycle, have a decreased frequency. So they have found out these are all the sexual difficulties they go through when they face with infertility. So another one is the chronic stress of infertility, the treatment, the outcome, the mental stress, which causes a release in the cortisol that affect the men also to have a low sexual desire as well as low sexual arousal. And that has an effect on their sexual function. What it was good for the fun and the pleasurable activity have become a very much do-to-do list. And that is a very important problem. The couple says that their sexual life is totally spoiled, and it even affect their intimacy. When sexual frequency becomes more a methodical, predictable, unexciting, and also it is always controlled by the doctor, not by their pleasurable way. So in that way, it is always a very important stressful effect on the couples, causing a lot of sexual dysfunction, both in the men and the women. And that sexual dysfunction itself makes them more go for a stress, which leads to the fertility issues, unnecessarily putting them into an advanced treatment. Instead of having a pregnancy in the bedroom, they go for the laboratory just because of the sexual dysfunction caused by the stress of the infertility. And other stress and lifestyle factors like sleeping, and these are all some important factors that we have to keep in mind. The unhealthy behavior that also can cause a stress, which itself lead on to a infertility issues. They either sleep too much or too little. They have a harder time of sticking to healthy eating habits, and they drink too much of alcoholic drinks because the depression itself pushed them to this unhealthy behavior, and that add-ons to the fertility issues. And because of the stress of the infertility, they drink, smoke, and all the unhealthy habits add on to the fertility issues, which also make the make their fertility issues still more severe and have a difficulty in them to get a conceive. So definitely stress causes a lot of effect on the hormone system, and the chronic stress have an effect on the hormonal changes, which leads to a problem of definite fertility. And there are very many studies which definitely says that the couple who report feeling good become more pregnant and early pregnant, easily pregnantly at a higher rate than the couples who report being tense and anxious. Similarly, women with higher level of stress have lower success rate with IVF than those who have a low level of stress. So how we are going to reduce this stress to improve their fertility outcome? So that is a very important question that we as a consultants should answer to give to our patient to treat them. So how to make them reduce their stress, which is a very important strategy that we should plan, not a routine way of giving medications, tablets, and other things. We have to support them in a good way of giving them a solution for how they have to overcome this stress. So we have to talk with them, counsel them, tell them about the effective procedures to reduce the stress. Also tell them about the pros and cons of the treatment proper, and give them a possible outcome success rate. So don't say that, okay, it's 100% success. As sir said, the 2 letrozole cycle, if they fail, they'll come and sit and they'll be crying and crying and crying. And sometimes they may even feel they're not fit to live at all. So like that, they feel a very extreme emotions because of the anxiety of the infertility. So we have to have a very proper counseling, very proper, tender, loving, affectionate care, and a very good supportive way we should teach this couple. That is very important to overcome this stress. Apart from our counseling, apart from educating them, apart them giving them a rationale, and apart there all the options of giving the treatment, outcome, success, everything, along with that, we have to give some methods to improve their stress level, to reduce their stress level, so that they improve in the fertility outcome. The stress reducing techniques which has been reported with the scientific evidence of, first is the acupuncture, second is a good aerobic exercise, third is you have to collaborate with the experts. They have to sit and talk. It should be done as a routine wise. In our clinical practice, we always do, after every session of a treatment failure, we do a counseling with us, with the experts. We have to give them a support, to give them a positive outcome, give them a positive supportive measures of talk and consoling. That's very important. And of course, we have to give them a images of what is proper, and give them the research-based, evidence-based studies to support their problem per se, and also make them understand, relax them in a better way, like relaxing to listening to the music, massage, meditation, and even mind body groups to be added together. And mindfulness therapy is very important, and progressive muscle relaxation is very important for a chronically stressed, unexplained couple people. So there is one study which says that in unexplained infertility, this type of a progressive muscle relaxation helps them to have a better fertility outcome. And also you have to have a support group, and also we have to make other forms of exercise like aerobic exercise, yoga, everything should be made. And regarding the sexual life, we have to make the sex enjoyable again, make them not, it is not for fertility or the pregnancy alone. It is for pleasurable way. So that is a very important thing that you have to do, and tell them the importance of the exercise. That will help them to improve their sex drive, as well as improve their mind and attitude towards a positive fertility. And that is the studies about the acupuncture. What they say is the hormones ACTH, which is released in response to acupuncture needle stimuli, has an anti-inflammatory effect that can improve the fertility. Thereby that improves the tubal factor and also improves the PID features also. And I have a data that we always educate or advocate acupuncture for our IVF patients. That has improved the success rate in a very good way. Prior to the ET and after the ET, we do acupuncture regularly for the couple. That improves their conception and IVF pregnancy rate. So acupuncture definitely have a play a role in reducing the stress, and that improves the fertility outcome. So these are the ways that you can counsel your patient when they come with a stress, which could be because of the fertility as well as because of the treatment. And definitely relaxation therapies, acupuncture, exercise, yoga, meditation, and a very tender loving care of counseling, and giving them the positivity of the outcome and the probability of the success, and giving them the options of the treatment, and give them the reality of the practical decisions to help them to make. That will help them to carry over the fertility treatment in the best way with less stress and more success rate. So with this word, I thank Sampath and the Tnfog team and my mentor, Dr. Revathi Madam, for this nice opportunity. And I'm open to questions.
Thank you, madam. Thank you so much. That was a very insightful talk. Actually, when infertility and the stress of infertility is equated to cancer, then probably the insurance and the funding from the government agencies.
You can stop sharing, I think.
Perspective rather than treating this as a luxury, the insurance company. The other thing is, yes, we have seen patients who are being controlled by the doctors for their this one. So every time we have to sit with them, talk to them, and tell that it is okay. And we've seen patients whose husband ran away at that particular time of follicular development. So those are the things that you have put in a very nice perspective. Thank you, madam.
Thank you, sir. Thank you.
Thank you, Jairani, for the beautiful talk.
Thank you, Annie. Thank you. Nice, Jairani. It's really very interesting one. The different aspect which you have to look at while treating infertility.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Thank you. Topic, madam.
Thank you.
Maybe you can introduce Dr. Subhashini next because Jairani, I would close for the kilamunga.
வெளியில காவல் காத்துட்டு இருக்காங்க, எப்படா மேடம் வெளியில போவாங்க. Thank you so much.
Bye.
Sampath Kumari ma'am, results are ready ma'am. Sampath.
Yeah, you can just share it. Chitra.
போடுமா சாகித்தி ரிசல்ட் போடு.
Okay, okay, ma'am.
So the first question, MHT except and the question team போட்டினா answer எல்லாருக்கும் தெரியும். The winner is Kalaiselvi Ramasamy from Salem. The mail ID la irukadnala I think shield people will approach you for giving the prize, whatever is there. Okay. Sakiti, can you?
Congratulations.
Congrats.
Congratulations.
The answer is except Armin of second. That's all. Now we will go to the second speaker. Dr. Miriani, you can introduce Sudhash.
Yes, ma'am. Yes, ma'am.
Yes, Mary.
Now, being everybody here and
Mary on a phone. Now we invite the first speaker to be
let me introduce Dr. Suhasini Karnal. She is Engelberg Medical DNB Hospital, Chennai. Additional things are hospital. She is current designations. She is working as assistant professor in Muthukumara Medical College for the past 7 years. And now Suhasini will be talking about dysmenorrhea, a very troublesome menace to the adolescents especially, and which goes till midlife. And then we have always found it a real challenge to tackle, because most of the cases turn out to be endometriosis, and then it's very difficult to convince the girls as well as the mothers when they come with dysmenorrhea. Now over to Dr. Suhasini for your talk now.
Suhasini was supposed to be the first speaker.
Shall I share the slides?
Very sorry, ma'am. I wasn't able to share the slides.
Yes, Suhasini.
Okay, now shall I share?
You can share.
Good.
So,
got it.
Good evening to everyone. My topic today for the session is dysmenorrhea. As the name suggests, dysmenorrhea. Dys means pain, meno means month, and rhea means flow. So every month, as the menses starts, the patient is going to get dysmenorrhea. That's painful menstrual cramps in the terminology. Next slide. So when you see the prevalence of dysmenorrhea among the menstrual disorders, it is most common, and it is accounting to 46.3%. So it is the most common symptom with which the patients come to the gynecological clinic. The next slide. So we have two types of dysmenorrhea. One is primary and the other one is secondary. Primary, that occurs in normal ovulation cycles without any pelvic or uterine pathology. It mostly occurs in the adolescent girls, especially within 1 to 2 years of menarche. The incidence accounts to 15 to 20%, and mostly the risk factors, if you see, it is from the students, that is adolescents from the higher society, socioeconomic class, and having high BMI, and it is familial. Next slide. So why are these periods very painful? Let's see what is the cause for the painful periods. So we have so many factors that are affecting the cause of dysmenorrhea. One is psychosomatic and lifestyle factors, effect of prostaglandins, effect of autonomic nerves, effect of progesterone, and effect of so many factors like vasopressin, endothelins, and platelet activating factor, and leukotrienes. Next slide. So these are the psychosocial factors that play a very important role in causing dysmenorrhea. The main thing is stress, anxiety, lack of any physical activities leading to obesity, and then smoking. Next. So this is a proposed mechanism of pain in a primary dysmenorrhea. So what happens after ovulation? There is a corpus luteal formation. Once it regresses, there is release of progesterone. Then progesterone causes increase in the prostaglandin levels, which in turn causes myometrial contraction and reduces the blood flow due to uterine ischemia, which causes pain. Next slide. Next slide, please. Next slide, next slide.
Okay.
So the next one is effect of autonomic nerves, where you have hyperactivity of the sympathetic nerves leading on to the hypertonicity of circular fibers of the
I'm not able to hear.
Yes, yes. Which leads to pain. So effect of progesterone, you have declined progesterones which trigger the lytic enzymes causing activation of the COX pathway. So there is generation of arachidonic acid and release of phospholipids which leads to pain because of the prostaglandins and thromboxanes. Next slide. Then you have the vasopressins and the platelet activating factor, endothelins and leukotrienes which are getting increased, which leads to myometrial hyperactivity and increased prostaglandins, and it stimulates uterine hyperactivity, dysrhythmia, which causes pain. Next. So what will be the clinical features in case of a primary dysmenorrhea? The onset is few hours before or just after the periods, which lasts for about 48 to 72 hours. Mostly it is of a spasmodic variety or a colicky in nature, and it is mostly starting from the suprapubic area and accompanied by lumbosacral backache, radiating to the anterior and the inner thigh. And associated with that, you have generalized weakness, and nausea, diarrhea, and gastrointestinal symptoms. Previous slide, sir. Previous. Yes. And you have associated symptoms like, you have skipped to the next slide, sir. Previous. Yes, sir. Yes. So you can see in this graph, there will be associated symptoms mostly with mood changes, backache, and then the GIT symptoms like diarrhea, nausea, vomiting, and associated with fatigue and headache and edema. Next slide. So investigations, primary dysmenorrhea, mainly you have to rule out the underlying pelvic pathology to distinguish between the secondary dysmenorrhea. So for that, you will do an ultrasound and a culture to rule out a pelvic inflammatory disease. Next slide. Treatment. First, the general treatment, home remedies like ginger, those things and all you can try. And then you have to improve the general health and hygiene. And you have to have a well-balanced diet during the periods. And then frequent bladder emptying and bowel emptying. Then you can engage themselves in simple sports activities or yoga. And a massage and hot application will also help them to relieve this pain. This is in case of a primary dysmenorrhea. Then you have the non-pharmacological methods like acupuncture and TENS, which is transcutaneous electric nerve stimulation. Next slide. Medical management, you have the non-hormonal therapies and the hormonal therapies. On the non-hormonal, you have NSAIDs like ibuprofen, mefenamic acid, ketoprofen, and COX-2 inhibitor like celecoxib. And in the hormonal side, you have the combined pills, estrogen and progesterone pills, and you have the progesterone-only pills. And you can also try for LNG IUS and GnRH agonist. Surgical methods, you have laparoscopic procedures like laparoscopic uterine nerve ablation, laparoscopic presacral neurectomy, and dilatation of cervical canal if it is a cervical canal stenosis. In laparoscopic uterine nerve ablation and laparoscopic presacral neurectomy, the pain is very effective up to 1 year, and later on the nerve degenerates, making the procedure. The pain reappears after 1 year. Next slide. So now, I'm finished with the primary dysmenorrhea. Now you go to the secondary dysmenorrhea. Mostly it is of congestive type. It is a cyclical pain and it's associated with the pelvic pathology. The incidence varies depending upon the type of pathology, and it is mostly seen in the late 30s and often multiparous women. Next slide. So here are the causes of secondary dysmenorrhea. The most common cause of secondary dysmenorrhea is endometriosis, and then you have the congenital obstructive Mullerian malformation, cervical stenosis, ovarian cyst, uterine polyps, uterine leiomyomas, adenomyosis, pelvic inflammatory diseases, and pelvic adhesions. Next. So pathophysiology in secondary dysmenorrhea is you have an underlying pelvic pathology which increases the vascularity, causing pelvic congestion and having pain. The clinical features, unlike in primary dysmenorrhea, here the pain begins 1 to 2 weeks prior to the periods and persists few days even after the cessation of the period. It is usually dull aching and is mostly confined to the back. It is non-radiating type of pain. Next slide. So if you go to the investigations, you have diagnostic and therapeutic. In the diagnostic side, you have an ultrasound along with abdominal and a transvaginal ultrasound. Then you have saline infusion sonography. In the therapeutic side, you have laparoscopy and hysteroscopy. So treatment, you have to treat the underlying disorder, and it depends on the type, severity, age, and parity of the patient. So why are we so stressing on dysmenorrhea? Because there is an impact of dysmenorrhea on the quality of life. You have 12% of adolescent women who are taking leave for the school because of the heavy pain and reduced physical activity. People have loss of confidence, low concentration, poor work satisfaction, and poor personal relationship. Because dysmenorrhea, we tend to think that dysmenorrhea is just a pain that is arising, but sometimes it can be very painful and it can affect the quality of life. They even take leave from their work or from the school. Next slide. So here I want to discuss about endometriosis in adolescents, because that's a leading cause of secondary dysmenorrhea in adolescent, and 2/3 of the adolescents who present with chronic pelvic pain or dysmenorrhea who are unresponsive to the medications like NSAIDs and OC pills, definitely you have to rule out endometriosis. The endometriosis is different from those of an adult, because in you do in laparoscopy, you can find out clear or red spots, unlike you in an adult where you can see powder appearance or an ovarian endometriotic cyst. So you, one has to be very careful when you do a laparoscopy in adolescent to find out the endometriosis especially. So what should be our goal of therapy? The first thing should be to give a symptom relief, that is to get rid of the pain, and then you suppress the disease progression, and then you have to protect future fertility. So therapy should be individualized. Conservative surgical therapy and should be considered, and suppressive hormone therapy should be given following the surgical therapy. Hormones can be either combined oral contraceptive pills or progesterone only pills, or LNG IUS can be used. If patient is still refractory to all those treatment, 6 months of GnRH agonist therapy with an add-back therapy has to be started. Next. So this is an overall flowchart to show when a patient comes to you with a history of primary dysmenorrhea. You start her on an empiric therapy with the NSAIDs or a hormone therapy. And if the patient responds to the therapy, you have to continue the same treatment, considering it as a primary dysmenorrhea. If the patient is not responding to the therapy, then you have to consider all the possibilities of secondary dysmenorrhea. You evaluate for secondary dysmenorrhea. You do a pelvic examination to do an ultrasound. Then if there is any positive findings, then you treat according to the etiology. And if there is any negative findings on the ultrasonography, you have to consider doing a laparoscopy and a hysteroscopy. You have to definitely rule out endometriosis. Next slide. So why suffer silently? Periods are normal, but period pain is not. So you should spread awareness, especially among the adolescents. You have to educate them and help them have a better quality of life by seeking right treatment. Thank you.
Thank you, Dr. Suhasini. That was an excellent talk, and the way you stressed upon the adolescent with endometriosis
and need of the art that we do.
Nice and crisp, Subhashini. Nice.
And she had beautifully illustrated also. Isn't it, ma'am?
மழை இருக்கு இல்லையா ரொம்ப அதான்.
ஆமா.
கேக்கலையோ.
Sahiti, you can put the second question for the session 2.
மேடம் இங்க பயங்கர மழை.
எங்க நாகர்கோயிலையா?
ஆமா, இது நாகர்கோயில்ல நியர் ட்ராண்ட்ரம்.
நல்ல மழை தான்.
சென்னையில ஸ்னோவாமே பனி பெய்யுதுன்னு சொல்ற ட்விட்டர்ல ஒரே தான் சண்டை போட்டுட்டு இருக்காங்க.
Yes. Yes, ma'am. Dear delegates, please answer the question. 1 minute.
Cause of dysmenorrhea with painful nodule in POD is adenomyosis, endometriosis, leiomyoma,
polyp,
and polyp.
20 seconds over.
Madam, நான் சொல்றேனே.
தெரியுமே.
ரொம்ப ரொம்ப ஈஸி क्वेश्चन கொடுக்கறாங்க. சம்பத்
என்ன டெலிகேட்ஸ்க்கு மேடம்?
Delegates,
40 seconds over.
Delegates
Okay, ma'am. Time up, ma'am.
To encourage the delegates. அதுக்காக.
ஆமா மேடம். நீங்க இந்த மாரத்தான் சீரீஸ் ரியலி ஒரு பெரிய ஒரு எப்படி
Evolution.
நீங்க நிறைய ஐடியாஸ்
இங்க வந்து அட்ரஸ் தேடி பிடிச்சி பிரைஸ் கொடுத்துறாங்க.
வெரி நைஸ்.
எல்லாருக்கும் கொடுத்தாங்க. இந்த வருஷமும் பிபி apparatus and ஏதோ ஸ்பெஷல் சம்திங் they do. Anyway, thank you delegates. The prize will reach your home by June.
யார் பிரைஸ் சொல்லலையே?
இது சொல்லுவா மேடம். அதுக்குள்ள vote of thanks பண்ணட்டும். அவ செலக்ட் பண்ணோம்ல ஃபர்ஸ்ட் இதுக்கு அந்த கலைச்செல்வி சேலம். இதுக்கு வந்து அவ அந்த இதுல இருந்து எடுக்கணும். அதுக்குள்ள we will hear Radha Madhavi. I request Dr. Radha Madhavi, the Joint Secretary of Tnfog and the President of the Tiruvannamalai Uji Society, for vote of thanks.
It is an honor and privilege to propose vote of thanks for this wonderful marathon CME. I thank the organizers, Dr. Revati Janaki Raman, Dr. Sampath Kumari, Dr. Vijay Lakshmi Gnanasegaran. I want to thank our chief guest, Dr. Sunita Tandulwadkar, and also wish her all the best for her forthcoming Foxy presidential election. I like to thank chairpersons, dear Mary Annie Raja, Dr. Sarvana Kumar, speakers Dr. Suhasini Karnal, Dr. Jairani Kamraj for their wonderful talks on dysmenorrhea and infertility. I like to thank our sweet senior moderator, Professor Revati Janaki Raman, the great Veena maestro. Thanks to her for conducting such a wonderful panel. Thanks to Dr. Lakshmi Krishna, Dr. Sanmaga Vadiyu, Dr. Manonmani, and Dr. Padma for enlightening us.
And Dr. Radha Madhavi.
And to make us boldly use MHT. Boldly use MHT from now on. And I like to thank Dr. Kalpana for introduction of our chief guest. Let us all meet again. Last but not the least, I would like to thank Shield, which is a wonderful partner for us for their wonderful tech support and support for TNFOG in all their academic activities. I like to thank Sahiti and team and Shield team for helping us conduct such a wonderful CME. Thank you.
Radha delegate, Radha.
Thank you, ma'am.
I like to thank the delegates for the wonderful participation and congratulations for the winner of the questions, Dr. Kalai Selvi and the lucky second person. Thank you.
Thank you, Radha.
Ma'am, results are out, ma'am. Shall I display, ma'am?
Yes, yes.
Rather, the day is done that use of MHT is understood. That's good.
Winner is
Yes.
Dr. Subhashini from Madurai.
Oh,
Madurai. Madurai, madam.
Subhashini.
Revati ma'am, Madurai.
Very good, very good.
Wonderful, wonderful.
Wins in the quiz also, IMS quiz also.
Yes.
Wonderful,
Thank
wonderful.
you for the winner. Thank you. Sahiti, you can.
Thank you.
Thank you, madam. Program.
Thank you, madam. Thank you for this